In this lecture, we are going to talk about drug distribution. So we're going to talk about drug distribution. Let's define what is drug distribution. So drug distribution describes the process by which a drug moves between the blood and various tissues or organs. Okay. So what could be examples of tissues? Tissues, for example, the muscle or fat, and organs could be example, the brain. Okay. So distribution, so what is this? This is the definition of distribution. Okay. So distribution describes the process by which a drug moves between the blood and various tissues or organs. Okay, so what we mean is that we take a drug and the drug gets into blood, and from the blood it moves into tissues or organs. Okay? And the way we describe this process, it is called distribution. So what if there is no distribution? What if there is no distribution? Okay, so that means the drug only enters into the blood. Okay, it doesn't go into the tissues or the organs. What is the consequence of that? The consequence is that the drug will now only be able to, the drug will only be able to act on the blood or the blood vessels. Okay. It wouldn't have any action at the if the receptor site is the tissue or the organs. Okay, so that is the importance of distribution. So if there is no distribution, the drug would reach the blood, and consequently it will be able to work only on the blood or the blood vessels. Okay, which blood vessels are we talking? It can be the veins or the capillaries or the arteries, okay, or the venules. Okay, so if there is no distribution, it would act only on the blood. It wouldn't be going to the tissues and organs. Now, if our target site of the drug is the tissue or the organ, then it needs to be distributed. Okay, so that is the importance of, that's the definition and the importance of distribution. Okay, so we have talked about the definition, and we have talked about the importance of distribution. Okay. So what we have just discussed above, let's go into a bit of detail. Okay. Um, so, how does the drug enter the blood? If we administer it by IV, what is IV? Intravenous, okay, or um, absorption, okay, absorption from uh, different sites of administration. It can be oral, it can be maybe subcutaneous, or um, any other route, okay, like nasal or so on. And what is the criteria? The drug should have high bioavailability. Okay. So if we administer a drug intravenously or we give it through any other site, and if the drug has got enough bioavailability, what's going to happen? This drug will enter into the blood. Okay. What happens after it enters the blood? So the drug from the blood, it goes into the hepatic portal circulation. And where does it go? It goes into the liver. Okay, so if that's the liver, it goes into the liver, it gets metabolized. Okay, it gets metabolized, and the metabolite and the drug enters into the blood. Okay, let us assume our assumption is that the drug is active and the metabolite is inactive. Okay, so this is our assumption, but that is just an assumption because for many drugs the metabolite is also active, and in some cases only the metabolite is active. Okay, so we will discuss those aspects when we talk about metabolism. Okay, but for now let's assume that the drug is active and the metabolite is inactive. So this active drug now reaches the blood. Okay, so what are we doing here? We're trying to trace the path of the drug after administration. Okay, so now it has reached the blood. Then what happens? Okay, let's write the question that we are talking about. What happens when the drug reaches blood? Okay, so we administered the drug reached the blood. From the blood it went into the liver, it got metabolized, and a part of it reached back into the blood. So now we are asking the question, what happens after the drug reaches the blood? So in the blood we have plasma proteins. Okay, there are lots of different types of plasma proteins. What are the different types of plasma proteins that we are talking about? Very good. Okay, so the plasma proteins, most important one would be albumin. Minor ones like hemoglobin. There can be lipoproteins. There can be alpha-1 glycoproteins. and there can be globulins. Okay. So in the blood there are plasma proteins, and the drug encounters these plasma proteins. Okay. What happens then? Okay, so we are now going to ask ourselves the question, what happens then? Okay. So the drug encounters plasma proteins. So let's schematically represent plasma protein. Let's call this plasma protein. Let's make it specific. Let's say it's albumin. Okay. Let's say it's albumin. Now, these plasma proteins, plasma protein has got hydrophilic groups. Okay. Hydrophilic groups on the surface, and jutting from the plasma protein would be side chains. Okay, so there are hydrophilic groups and there are side chains in the plasma protein molecule. Okay. So these side chains and the hydrophilic groups okay, they have reactive groups. Okay, they have reactive groups. And what is the consequence of having these reactive groups? These reactive groups, they permit reversible binding of structurally diverse small molecules. Okay. So these reactive groups, they permit the reversible binding of structurally diverse small molecules. Okay. Meaning this plasma protein can bind to drugs which have got a varying structure. Okay. It's not like a receptor binding to a particular structure. Okay, they can bind to different small molecules which have got diversity of structure. Okay, so that's why we say structurally diverse. Okay, all right. So these plasma proteins can bind to more than one type of drugs. That's what we're trying to say. Okay. So these drugs can bind to. So what happens next? The drugs bind to this reactive sites of plasma proteins reversibly. Okay, so what do we mean by reversibly? We mean that the drug is not binding by covalent bonds. Okay, it might be attaching by weak bonds like van der Waals bonds. Okay, so the drugs bind to these reactive sites of the plasma proteins reversibly. Okay, so let's ask ourselves the question. Next question. Okay. And the next question is, what is the consequence? What is the consequence of this reversible binding? So does what happens when the drug undergoes this reversible binding? So to explain this, let's take two molecules of a drug. Okay, let us take two molecules of a drug. Okay, let's depict them as the two molecules as A and A. Okay, so this is molecule 1 and this is molecule 2. And let's say there is a plasma protein. Okay, let's depict a plasma protein as before. Okay, let's say there is a hydrophilic reactive group out there. Okay, so we said that the drug binds reversibly. Okay, so what happens? This drug encounters this plasma protein, and this is what happens. We've got this plasma protein with the hydrophilic site, and let's say one of these molecules, this molecule A, comes and binds reversibly to the plasma protein. Okay, and then what we observe is there is a form of the drug molecule which is unattached. Okay, so now we define the one that is having an interaction or bound to the plasma protein. We call it the bound drug, and the drug that is in the unbound form we call it the free form. Okay, so what's the consequence? The drug encounters the plasma protein, and some of it gets bound and some of them remain in the free form. Okay, now only the free form of the drug, only the free form of the drug is active. Okay, only the free form of the drug is active, and only the free form of the drug is available for biotransformation, transfer across membranes, and for excretion. Okay, so only the free form of the drug is active and available for biotransformation, transfer across membranes, and excretion, which means the bound form is inactive. Okay, the bound form is inactive. Okay, so now we have an equilibrium. We have got the plasma protein which is bound to the drug. Okay, and this is in equilibrium with the free form of the drug and plasma protein. Okay, so this is ultimately what we understand from our discussion thus far. Okay, so what it means is that suppose we've got this bound form of the drug. Okay, in the plasma we've got this bound form of the drug, and we have got the free form of the drug. Okay, so now imagine these things are in the blood. Okay, so that is a depiction of a blood vessel. Okay, so we by absorption and by by either absorption, or by intravenous administration. The drug enters into the blood, and here we've got this blood flowing. Okay, and what's the drug? We have injected two molecules of the drug molecule A, and A reaches the blood. It encounters the plasma protein. Okay, once it encounters the plasma protein, what happens? One molecule binds to the plasma protein and one molecule is free in the blood. So what did we say here above? We said that only the active form of the drug is available for excretion, transfer across membranes, and biotransformation, meaning only this drug is active. Okay, and suppose the site of action of the drug A is an organ. Okay, let's say this is an organ. Let's say this is the heart. Okay, so this is the heart. So this drug, the target organ, target site of the drug, the free drug is the heart. So what happens is, and we said it is only the active form that is, only the free form is active. So what happens for it to act on the heart? It needs to cross this membrane. Okay. Okay, it needs to cross the membrane. Then it reaches the heart. It reaches the heart. It needs to cross the membrane. So what did we say? Only the active form of the drug is available for biotransformation, transfer across membranes, and for excretion. Okay, so only the active form gets into the tissue. The bound form remains in the blood. Okay, so suppose it has gone to the heart. Okay, so now what we have a situation where we have got this blood vessel, we've got this plasma protein, and we've got this plasma protein is bound to the drug A, and the free drug has entered into the tissue. It has entered into the tissue and it has gone to the heart. Okay, so as a result, what happens? There is no free drug in the blood. So now what happens? Because there is an equilibrium between the bound form and the free form, what happens? There is transfer of the bound form of the drug into the blood. Okay, so what happens? Let's draw it here. What happens there is that the bound drug leaves the plasma protein and becomes the free drug. Okay, and that free drug is now available for action. And suppose, say, this free drug is excreted. Okay, maybe through the kidney. Okay, because blood goes into the kidney and then it gets filtered and maybe it gets excreted through the kidney. So then finally what happens is you've got only the plasma protein. There is no drug there in the blood. Okay, so this equilibrium is important. So when the concentration is high, what happens? The drug gets bound to the plasma protein, and as the drug gets removed either by going into the tissues or by being excreted, more and more drugs would be released from the bound site. Okay, so is that a consequence of plasma protein binding? Yes, it is. So that is the first consequence. Okay, that is the first consequence. Okay, let's look at the second consequence. What is the second consequence? We'll take up the story again of the drug being bound in the blood vessel. That's the plasma protein, and the drug is bound to the hydrophilic moiety on the plasma protein, and there is the free drug A. And this free drug we said is active. And let's imagine now that it crosses the membrane. Okay, it needs to get out of the blood vessels to go into the tissues or the other fluids. Okay, so let's assume that the drug A is lipophilic. And because it is lipophilic, it can cross the membrane. Okay, so it crosses the membrane. So if it crosses the membrane, where can it go? It can go into the interstitial fluid, which is the fluid which bathes the tissues. Or where could it go? It could go into the intracellular fluid. What is the intracellular fluid? The fluid within the cells. Or it can go into the tissues. Okay. So here we have assumed that the drug is lipophilic. So can we have examples of organs which have got high lipid content? Yes, very good. Okay, so the organs which have got a high lipid content would be the brain and the fat tissues. Okay, so we have assumed our drug to be lipophilic, so it goes into the tissues and it preferentially goes into the brain and the adipose tissue, the fat tissue. Okay, and then it dissolves in the fat because it's lipophilic. Okay. So now what happens? This drug has left, so there is a drug here, okay, and the bound drug has now, the free drug has already reached and it is now present in the brain and the fat. Okay, we've got the drug is now present in brain and fat, but it has moved away from the blood. The free drug has moved away from the blood. Now, there is a bound molecule of the drug present, and because there is no more drug in the blood, the equilibrium that we discussed, the bound form will go into the free form. Okay, so what will happen? Okay, so the drug will be released from the binding site of the plasma protein, and now that drug is now present in the free form. And what will happen? The concentration of that free form of the drug is greater than the tissues. So it will again go into the tissues and it will go into the brain and fat. So ultimately what happens is, we've got this plasma protein here without a drug, and there is no drug here, but there is an increased concentration of drug in the brain and fat. Now what happens? The concentration of the free drug is greater in the brain and fat. So what will happen is, here the concentration is high, so it will diffuse back into the blood. Okay, so it will go into the blood. So this is called redistribution. Okay, all right. Okay, so that is the second consequence of a free drug crossing the membrane. Okay, so that is the second consequence. So what were we talking about? We were talking about what is the consequence of reversible binding. Okay, so what was the first consequence again? Right. Okay, only the free form will enter it will cross the membrane, and then there can be redistribution. So those are the two consequences of this reversible drug binding. Okay. So when the drug, in this case this lipophilic drug, binds to the brain and the fatty tissue, and it remains there, we call it a depot site. Okay, so what is a depot? A depot is somewhere where you store stuff, right? So the drug gets stored in the brain and fat adipose tissue. And so it's available when the concentration of the free drug in the blood reduces. So what will happen? It will move back from the depot to the blood. Okay, so that is what we discussed here. Okay, so from the depot, it is going back into the blood. So what's a depot? It's a storage site. So what can happen? The drug can get, if it's a lipophilic drug, it can go into lipophilic sites, lipid sites, and then it can form a depot. And from the depot, it would be available. So what's the consequence of that? The drug will have a long half-life. Okay, it will be present in the body for a very long time. So lipophilic drugs will have a long duration of action. Okay, so that is the one of the main consequences of plasma protein binding. There is a third important clinical consequence of protein binding. Okay, so let's look at that. And this is drug interactions. Okay, so let's see what we mean here. For that, we need to look at a plasma protein, let's say albumin in particular. Okay, so we said it's a plasma protein, so it's got a molecular weight of 66,400 Daltons. Okay, so that's the molecular weight of albumin. Now, this albumin has got two sites. Okay, it has got two sites which, as we previously mentioned, have reactive groups. Okay, there are two sites which have reactive groups. Okay, so which have, consequently, those are the binding sites. And what are the sites named? They are named site 1 and site 2. Okay, so albumin has got two sites where it can bind drugs. Okay, so physiologically, what is the need for this site 1 and site 2? So physiologically, meaning in a normal body, the site 1 transports it transports bilirubin, and site 2, it transports the amino acid tryptophan. Okay, so that is why it has got two sites, because in the normal physiology it's got this function. It transports bilirubin at site 1 and it transports tryptophan. But we said that these sites contain reactive groups, and now when we give a drug, these reactive groups, there is an interaction between our drug and the reactive groups, and that may sometimes displace the endogenously bound substances. For example, if we give sulfonamides, okay? Now sulfonamides have got have got a greater affinity for the reactive groups at site 1, and consequently, if we give sulfonamides to a normal person, what's going to happen? The sulfonamides will displace bilirubin from the binding site. Okay, it will displace bilirubin displace bilirubin from the bound site and get attached to the bound site. Okay, so it will go and sit at the site 1. Okay, so yeah, so sulfonamides have got this property. Okay, so there are certain drugs that bind to site 1 preferentially. Okay, so let's have a list of those drugs which bind to site 1. Okay, the drugs which bind to site 1, drugs binding preferentially to site 1, and the drugs are warfarin, phenylbutazone, phenytoin, valproic acid. Okay, so the anti-epileptic drugs and sulfonamides we mentioned here. Okay, so these drugs, they displace bilirubin and they get bound to site 1. Okay? And there are certain drugs which bind to site 2. And do we have a list? We certainly do. Is it exhaustive? No. Okay, so these are representative examples. And the NSAID, ibuprofen, indomethacin, libenclamide, tolbutamide. Okay, so you know the anti-diabetic drugs and the NSAIDs. Okay, so they preferentially bind to site 2. So as soon as we give this drug and this drug enters into the blood, it binds to site 1, and these drugs bind to site 2, and in that bound form they are transported. But remember that they are in equilibrium. Okay, so if warfarin binds to site 1, there is also free warfarin in the blood that's pharmacologically active. Okay, so this is a now there can be drug interactions. So now if there are differences in affinity between two drugs, so if we give two drugs simultaneously, then what can happen? There can be a displacement drug interaction. Okay, for example, if we give phenylbutazone to a person on warfarin, what will happen is phenylbutazone will displace warfarin. So what's the consequence of that? Free warfarin will increase in the blood. Okay, we mean the plasma. Okay, so the free warfarin will increase in the blood, and what will happen? So we said free drug is more is pharmacologically active. Now there will be a great concentration of the active form of the drug. As a result, there will be there can be spontaneous bleeding. Okay, so plasma protein bindings have got a potential for drug interactions if there are drugs bound to site 1 or site 2. with the endogenous bilirubin or with if more than one drug is given simultaneously to the patient. Okay. So what have we been talking up till now? We've been talking about the consequence of drug binding. So distribution. What is important in distribution is plasma protein binding. And that plasma protein binding has got consequences. The first consequence was that only the free drug is active. And it's only the free drug that is available for biotransformation and excretion and transport across membranes. Okay. And the second consequence, what was the second consequence? Yes, we said that lipid soluble drugs can form depot. Okay, highly lipid soluble drugs form depot. For example, the contraceptives, okay, steroids, they form depot preparations, okay, estrogen and conjugates of estrogen could be an example. What's the third consequence? The third consequence is there can be displacement drug interactions. Okay, what was the example that we gave? We talked about phenylbutazone displacing warfarin from the binding site. Okay, which binding site? Site 1. And as a result, what happens? There will be increased concentration of free warfarin, and that can lead to spontaneous bleeding. Okay, so that would be a clinically significant displacement drug interactions. And there are lots of other drug interactions as well. Okay, so this is where we are at, right now. Okay, we've talked about the definition, we've talked about the importance of distribution, and we have, in distribution, we have talked about the most important concept of plasma protein binding. Okay, and the consequence of plasma protein binding. Before we discuss further, it is important for us to remember as a rule of thumb for the drugs bound to the sites on plasma proteins, that plasma proteins have high affinity for acidic drugs. Okay, so what are the examples of acidic drugs? Right, warfarin, NSAIDs, penicillin, sulfone amides, and salicylic acid. Okay, so remember this interaction. Sulfonamides can displace bilirubin, and if it displaces bilirubin, what happens? It gets deposited on the brain tissue, and that can result in a condition called kernicterus. Okay, kernicterus. Okay, so from this we can have examples. So salicylic acid can displace bilirubin. Sulfonamides can displace bilirubin endogenously, and therefore they can cause kernicterus. So so those could be examples of drugs which can cause kernicterus. Okay, so that's something to keep in our mind before we continue our discussion. As a rule of thumb, we also need to remember that what were the plasma proteins that we talked about? The examples of plasma proteins, do you remember? Right. Right. So the rule of thumb to remember is basic drugs are preferentially bound by alpha 1 glycoproteins. Okay. That could be another rule of thumb for us to keep in mind. Okay. Are there any other consequences? Yes, there are. Okay. So let's look at another consequence of plasma protein binding. Okay, let's say number 4. Okay, toxicity. Okay, so certain drugs would be distributed to certain end organs, and that may result in toxicity. Okay, for example, chloroquine. Okay, it gets preferentially transported to the liver. Okay, so that is the reason why it is used for amoebic infections, okay, of the liver. And it is also distributed to the retina. Okay, and therefore, what's the side effect that is seen? Yes, retinopathy. Okay. Because it is transported to the retina. Yeah. Then, is there another example? There is a drug, immunoderone. Okay. This drug is transported to the cornea. So corneal deposits are seen. Okay, we see corneal deposits. Okay, because this drug is preferentially transported to the cornea. Okay, is there any other clinical application for distribution? All right, so we need to remember that if the drug is widely distributed, then hemodialysis for removal is not a good option. Okay, so hemodialysis is one of the methods by which the drug, especially in overdose, can be removed from the plasma. Okay, but this is not a choice if the drug has got a vast volume of distribution. Okay, so if the volume of distribution is less than 5 liters, meaning it's being in the vascular compartment, then only then hemodialysis is a choice. Okay, so this is something to be kept in mind. Okay, so let's write this again. As the consequence. Okay, so we looked at 3 consequences, and then there is this 4th consequence, which is the toxicity of drugs in certain organs or tissues. Okay. Is there another consequence? Yes. Choice of hemodialysis depends on volume of distribution. Okay, so those would be the most important clinical consequences of plasma protein drug binding. Okay. Okay, we also need to remember which is the site where is plasma proteins synthesized. Okay, or which organ synthesizes plasma proteins? You are absolutely right. It is the liver. Okay, so what happens if there is a problem with the liver? Say hepatitis, or maybe a person has undergone surgery. What could be the consequence? Right. So less plasma protein would be synthesized in such people. Okay. So for example, what could be the disease? Say cirrhosis, or a chronic alcoholic who has got cirrhosis. Okay. So what will happen? Albumin would decrease. So if albumin decreases, what happens? Plasma protein binding would decrease. Now if plasma protein binding would decrease, what will happen? Free drug levels will increase. So dosage adjustment needs to be done. Okay. So yeah, so let's write it down here. Bound form of the drug would reduce. Okay, so as a result, free form will increase, and that will relate to increased activity. Okay, so we need to adjust the dose in case of liver diseases. Okay, so this needs to be kept in mind. Okay, so why is this important? Because depending on the status of the liver, the dosage can be adjusted. Okay, and sometimes if it's a very significant problem, the drug can be altogether avoided, and an alternative can be prescribed instead. Okay, so important for us to keep in mind. Let us now schematically summarize what we have learned thus far. Okay, so we introduce a drug into, let's say, the plasma, and from the plasma we said the free drug enters into the tissues. So let's write it here. Okay, so this is the plasma, and it enters into the tissues, and it can enter into the cells. Okay, so in the plasma we said that the drug, there is an equilibrium between the free drug and the bound drug, and the free drug passes through the, this is the interstitial fluid, into the tissues, and in the tissues again the free drug is in equilibrium with the bound drug, and this free drug again crosses over the membrane into the cells, and here again there is an equilibrium between the drug and the bound form. Okay, so what's important to remember here is that the drug crosses membranes. Okay, so this is a membrane, as is this membrane. Okay, as is this membrane. Okay, so the drug has to cross membranes to enter into the different compartments. Okay, So how do we introduce the drug into the blood? Either by intravenously or absorption from other sites. Okay. So these other sites, this is called peripheral compartment. Okay, the fluid part of the blood is called plasma, and this plasma is called the central compartment. Okay, from the central compartment, it passes through other areas. So the drug is in a bound form in the tissues. And what are the bound forms in the tissue? Where is it bound? It is bound to intracellular proteins and constituents like fat. Okay. So where is it bound in the tissues? It's bound to intracellular proteins and the constituents. And where is it bound? In what form is it bound in the cells? Where is it bound? It is bound to cell and interstitial membranes. Okay? Yeah, cell membrane. Okay. So those are the forms in which it is bound. And then what did we say? We talked about that from the cells and tissues, the drug can go back into the plasma when the concentration of the drug, free drug in the plasma decreases. And what is that called? That is called redistribution. Okay, what is the consequence of redistribution? The drugs have got a very long T-half. Okay, so let's give an example. Suppose an anesthetic, okay, a lipid-soluble anesthetic, say thiopenton is given to the patient. So what's going to happen? The drug, because it is highly lipophilic, is going to cross all these barriers. It's going to get bound to the lipid part of the cells and tissues, and consequently the concentration of drug in the central compartment will decrease, and then slowly drug is going to be released back into the central compartment. So what's ultimately going to happen? The drug is going to have a very long T-half. Okay? So concepts like so questions like why thiopenton has got a long T-half, or why is a loading dose given. So such concepts can be explained if we have an understanding of drug distribution. So this summary is a framework for us to understand the factors which determine drug distribution. Okay? So the factors that determine drug distribution. So they can be broadly classified as physicochemical factors, and physicochemical factors, the most important one is lipid solubility and the degree of ionization. Now, we said that for the drug to reach different compartments, it needs to cross the membranes. Okay, so for crossing membranes, the most important determinants are lipid solubility and the degree of ionization. So in one of the previous lectures, we've talked about how these two factors, we had a discussion of these two factors. Okay. Yeah, so the important thing to remember here is only a drug with sufficiently drugs which are sufficiently lipid soluble, only those would be able to cross the membranes. And then the degree of ionization. So highly ionized drugs will not cross the different membranes. Okay, so yeah. So the next factors which determine drug distribution are biological factors. Okay, so uh, we talked about a drug being bound to the plasma protein, and we said it is the free drug that crosses the membrane and is available. Okay, but the body uh, prevents certain areas of the body from having access to everything that is in the blood. So that is, everything that is in the blood does not reach all the tissues and organs of the body. The body prevents potential toxins from entering certain critical sites of the body. And wherever the body has got that kind of demarcated site, we say that those sites are protected by barriers. And the most important barriers that we need to know are the blood-brain barrier, the blood-brain barrier, and there is the blood placental barrier, and there is the blood testis barrier. Okay, so just by looking at this, we would understand why the body would require a barrier. Okay, so if everything that is present in the blood would reach the brain, then the brain, potential toxins can really damage the brain, and that might not be conducive for the organism. And if the potential toxin crosses over to the next generation, then that also wouldn't be a good idea. Okay, and similarly, if the potential toxin would cross and go into the germ cells, then that would in turn affect what happens to the next generation. So again, that would be a bad idea. Okay, so that is why evolutionarily these barriers have been designed to prevent toxins, potential toxins, which are usually water soluble, from entering these sites. Then the question is, we also have nutrients that are water soluble. Okay, so these nutrients should get into the brain, but it should not get through the barriers, but it should not, but the potential toxin should not enter. Okay, so selective entry should be there. Okay, so nutrients should enter, but potential toxins should not enter. Okay, so how does the body manage this? The body manages this by having carrier-mediated transport. Okay, meaning special proteins are available which carry the water-soluble nutrients through these barriers. Okay, and because these carriers are specific for those nutrients, it would not allow the potential toxins to enter via the same pathway. Okay, so there are different barriers. Okay, so fetal and maternal membranes, they are separated by a layer of trophoblastic cells in the chorionic villi, and that acts as a barrier. Okay, so in the blood-brain barrier, we've got capillaries, of the brain, the cerebrospinal axis, and these capillaries have tight junctions. Okay, so there are no pores or gaps, and this prevent basically the potential toxins from entering the drug. Okay, and yeah, so similarly here, okay, there are barriers in the blood testes. Okay, there is also a barrier out there. Okay, so right. So those are the most important things to remember about the these barriers. Okay. So the point is, we said the most potential toxins are water soluble, which means lipid soluble drugs can enter. Okay. For example, alcohol or general anesthetics, okay, can cross these barriers and enter this particular areas. Okay. Sometimes certain drugs, say fluoroquinolones, okay, their concentration in the CNS is less than that what is expected, less than that expected. Okay, this fluoroquinolones, they have got a lipid solubility, but still their concentration is less than that is expected in the CNS. The reason is there are certain efflux proteins. Okay, so efflux proteins are basically pumps that pump the drug from within to outside. Okay, so the drug that reaches the CNS is removed from the CNS by the efflux pumps. Okay, so the most important efflux pump is P glycoproteins. Okay, so what are the things that eliminate drugs from reaching these sites? They are the these barriers as well as efflux proteins. Okay, so barriers and efflux proteins. Okay, so they prevent distribution of certain drugs. Okay, all right. Then the next one is blood flow. Okay, so by blood flow we mean so how does distribution happen? Sorry. So let's ask a question. How does distribution happen after the drug reaches blood? Okay. So this distribution happens because the heart is pumping. Okay. The heart pumps the blood, and because of that the blood moves around, blood moves and transports. Okay, so there are certain organs are well transfused. Okay, so they've got good, so a better word would be they are well perfused. Okay, certain organs are well perfused. So can we have examples? Yes, so the heart, the liver and the lungs and the kidneys. Okay, so they are well perfused, meaning whatever reaches the blood reaches these organs very fast. Okay, and there are certain organs that are not well perfused. Okay, do we have examples? We do. For example, fatty tissues and bone. Okay, so these tissues are not well perfused. So the organs which are well perfused, they tend to accumulate the drugs more than the poor perfused tissues. Okay, so the well perfused tissues, they accumulate drugs more. Okay, so the rate of blood flow is a factor that determines drug distribution. Okay, then the body mass index. Now, if you think about it, the body mass index will vary in males and females, and the fat distribution would be different as well. Therefore, body mass index in males and females, so depending on the sex, it will be different, and that in turn will affect how the drugs are distributed. Okay, so then there is the biological factor that controls, that is plasma protein binding. So this is again important. We have discussed the important sites and the important drugs. Remember, we talked about the acidic drugs being highly protein bound. Okay, so there is a small thing that we need to remember about alpha-1 acid glycoprotein. Okay, this is again a plasma protein that is important for drug distribution. Okay, this alpha-1 glycoprotein, the concentration of alpha-1 glycoprotein increases after trauma, okay, it increases after trauma, it increases after surgery, okay, and it increases in inflammatory diseases. Okay, so suppose there is a patient with an inflammatory disease and the patient is given, say, quinine, because that patient is suffering from malaria. Okay, so this patient has been given quinine. Now, alpha-1 glycoprotein has increased. Okay, so what's going to happen is whatever quinine we give is going to be bound with this extra alpha-1 acid glycoprotein. So consequently, the free quinine, remember, free quinine is the active drug, the free quinine decreases. Okay, so as a result, the drug won't be effective in this kind of a patient. Okay, so that's the thing we need to remember about alpha-1 glycoprotein. Okay, so tissue binding again, the next factor. Again, it is related to the amount of the fat or other components that the tissues have, the cell membranes, etc., and that in turn would depend on the whether the drug is lipophilic. Okay, so those are the most important factors which determine drug distribution. Okay, so let's look at again the what are the different types of plasma proteins that we were talking about. Plasma proteins which are responsible for binding of proteins. Okay, so now let's put in some more information. We talked about albumin binding to acidic drugs. Okay, okay, like warfarin, penicillin, etc., that we discussed. Okay, let's look at globulins. Okay, globulins bind to, let's look at different globulins. Got transferrin. Okay. Transferrin binds to iron. We know this. Then it also binds to another globulin, binds to vitamin B12, okay, transcobalamin, and we have thyroid binding globulin. Okay, that binds to the thyroid hormone, and there is ceruloplasmin. Okay, that binds copper. Okay, so those could be examples of globulins. Now, alpha-1 glycoproteins, let's look at them. So they bind basic drugs. And do we have examples? We do have, okay. Chlorpromazine and imipramine. Okay, those could be examples of drugs which bind to alpha-1 glycoproteins. Okay, so once more we need to remember that binding to albumin is non-specific, meaning structurally non-specific drugs bind. And the important drug interactions we talked about was displacement drug interactions. Okay, so do you remember that? We talked about displacement drug interactions. We talked about phenylbutazone. Okay, let's see if we can write more examples here. Okay, so phenylbutazone displacing warfarin was one of the examples. So there can be other examples which are clinically significant. Salicylates displace warfarin. Okay, salicylates can also displace warfarin, and salicylates. An example of a salicylate? Yes, aspirin. Okay, acetyl salicylic acid. So salicylates or drugs like clofibrate, they can displace tolbutamide. Okay, so if they displace tolbutamide, what's going to happen? Increased free tolbutamide would be available, and that can cause hypoglycemia. Okay, so there can be that consequence of that. Yeah, so those would be some of the more important examples. Okay, so yeah, it is useful to remember these examples again. Okay, so during the course of this lecture, we have talked about lots of things about drug distribution. So let's summarize. We learned the definition of distribution. We talked about the importance of distribution. We talked about the most important aspect of drug distribution, namely plasma protein binding, and we said it has got certain consequences. And we understood that free drug is the active form of the drug, and it is this free drug that is available for biotransformation, for excretion and transport across membranes. And we understood that lipid-soluble drugs can form depot. And we talked about important displacement drug interactions, which is again the consequence of plasma protein binding. And we talked about toxicities in certain organs because the drug gets distributed to those organs. And we said that hemodialysis is not a good idea for drugs which have got a large volume of distribution. Okay? And then we talked about the factors determining drug distribution. We said that there are two types of factors. We classified them as physicochemical factors and biological factors, and the most important thing about them, of the physicochemical factors, are lipid solubility and degree of ionization. And the biological factors, we talked about different barriers. Which barriers? Right. Blood-brain barrier, blood-testis barrier, and blood-placental barrier. Okay, we talked about the blood flow. We talked about how certain organs are well perfused and certain organs are not. And depending on that, the drug extraction will be different. We talked about BMI. What's BMI? Body mass index. And we said that this varies in males and females. As a result, distribution might be different. And we talked about plasma protein binding. We talked about alpha 1 acetylglycoprotein. We talked about albumin, and we gave examples of those drugs. And we said there are certain disease conditions, as example, liver. Liver incidentally produces plasma protein. So if there are diseases of the liver like cirrhosis, in those patients, the plasma protein binding might be less. Consequently, the free drug would be more, and then that can lead to sometimes toxicity. So dose needs to be adjusted, or the drugs need to be substituted. And we talked about certain drugs have got increased tissue binding, and that the toxicity in certain tissues would be higher. Okay. So with that, let's wind up this introductory lecture on drug distribution. Okay. Thank you for your attention.